Hello, welcome, welcome. Welcome to OBHealthy, and this is the Physicians Health Network. I'm Dr. Omar Bey, and we're a group of physicians and Black physicians and we have two primary, I should say, primary focuses. The number one is to improve healthcare in people of African descent. So important, all righty? And the second one is to let young brothers know that it's possible to go to medical school and become a doctor. We are, we're enthused when we see a young Black male wanting to come into medicine because you need it, you need it. Understand that our webinar is every second Saturday at 1 o'clock. And if you want to see any of our past webinars, you just have to go to OBHealthy's website, scroll down to the bottom, and hit the YouTube symbol. That will bring up the whole channel of all of our past webinars. And you can look at any and every one of them. There's so much information there. All righty. When you go to the webinars, please subscribe so YouTube can continue to bring it. We'll continue to be able to bring these webinars via YouTube. I'd like to thank OBHealthy for allowing us to bring this webinar to you every month. And the most important thing that I can say today, please do not change any aspect of your medical care until you consult your physician. Only your doctor, remember, only your doctor can truly take care of you from a medical standpoint. And if you have a question, please type it in. We would love to answer your questions. And today's topic is orthopedics. So when you're my age, believe me, orthopedics is important because arthritis, hip replacement, joint replacements, these seniors falling and fracturing a bone, it happens too often. So this is something that I think we all should know about. And we have the perfect person to talk about this, one of our own, Dr. Lee. And but we're going to get started. First thing I'd like to do is let us introduce ourselves. Dr. Court, can you chime in and introduce yourself, please?
Hello, good afternoon. My name is Dr. James Court. My practice is in internal medicine. I'm located at East Orange, New Jersey. My primary hospital is Lower Bethesda Medical Center.
All righty. And Dr. Court's being humble, but he's in Guyana and he is tuning in.
Yes, sir.
I love it. I love it.
Right on time.
All righty. Dr. Lee, please.
Good afternoon, Dr. James Lee Jr., board certified orthopedic surgeon. I'm second generation physician. I practice mainly out of Essex County, New Jersey.
All right. And Dr. Salam. Yes.
Good afternoon, everyone. My name is Dr. Kareem Salam, and I practice in the city of brotherly love and sisterly affection, more commonly known as Philadelphia. I'm a board certified adult and child and adolescent psychiatrist, and it's an absolute delight to be a part of this webinar. In the service of the second goal, inspiring young brothers to become physicians, I have a few super quick book recommendations. Number one is A Young Boy's Search for the Original Black Doctors by Dr. Darrell Hill, who's an internist. He practices in Laurel, Maryland. The second book is Tools of Excellence, A Hood from Hood to Hooded, A Guide to Becoming the Physician You Dream by Dr. Aldwin Sumer, who recently graduated from medical school. I can include the information of these books in the chat to encourage young brothers to go into medicine. Thank you so much.
Excellent, excellent. Also, and as far as the questions are concerned, you can go to the area Q&A and type your question in if you have a question for any of the physicians. And it doesn't have to be about orthopedics. It can be anything in medicine, and we will try to answer that question. But we're going to start off with orthopedics. And Dr. Lee has prepared, what he's prepared is awesome. So what we're going to do is I'm going to use some of my limited skills, computer skills, to bring this up Bear with me. All righty.
Oh, thank you so much,
Can you see
Omar.
that?
I can. Thank you.
All right, it's yours.
All right. Well, great. I want to paint a scenario, tell a little story. So as an orthopedic surgeon, one of my duties in covering emergency room and hospitals is to help assist taking care of people who hurt themselves. And commonly we see hip fractures. And so many of us know in this day and age, we're living longer, we're getting a little older, medicine's a little bit better. And as a result, there's more chances to break bones or have an accident. And so what we have here are two x-rays. And for me, on the left-hand side where there's a black circle, what I'm showing is a broken hip. And in this case, you have a 82-year-old female. She has a history of high blood pressure, diabetes, and has mild renal failure. She is what we call a community ambulator, meaning she's able to get around her house, grocery store, basic errands on a daily basis, limited driving. So the functional level is pretty reasonable. And so unfortunately for this person, she slipped and she fell and she fractured her hip. So I get a phone call from the emergency room and says, you know, Dr. Lee, we have a nice 82-year-old patient. She slipped and fell. She broke her hip. And I circled in black a broken bone. So if you compare that black circled area to the other side, you can see how the other side looks normal. But in this case, you see what we call a fractured hip. And one of the analogies I like to use in the office or when I'm in the hospital is imagine you have a ice cream cone with a scoop of ice cream on it. Now, when that ice cream scoop is on top of the cone, it's easy to eat. It works out okay. But imagine if that falls on the floor or it starts to melt. And in this case, that ice cream scoop is that top of the hip bone called the femoral head. And when that breaks, unfortunately, in this case, the blood flow changes. And so we're not able to save it, meaning we can't just put screws in there and say, okay, we'll put it back. It's like trying to scoop a melted ice cream off the floor and putting it back on your cone. You can't do it. It's not going to work. So in this particular case, what has to happen is I see the patient, the admitting physician, someone like Dr. Court or who was an internal medicine doctor who knows the patient says, okay, Dr. Lee, you know, this patient has had blood pressure for 20 years. It's under control. You know, the issues with the kidneys have been managed by the kidney doctor and it's okay. She doesn't need dialysis. She was on a blood thinner, but we're going to stop the blood thinner. And I'm going to tell you, this patient is what we call moderate risk, meaning, okay, I think as I go into the surgery thinking, is this patient high risk? Are we really worried that maybe there'll be an event during surgery? Was it moderate risk or low risk? And how that's done typically is how old the patient is and whether they have any underlying health concerns. And Dr. Bay as well, he works in the ICU. He deals with pulmonary issue. He's also is aware of these types of patients and can help, we call risk stratify. Say, hey, doc, this is what we think. I think you have about a 24-hour window to get this done, and we think the patient will do okay. So from that point, I say, okay, I kind of know what's going on. Then I try to talk to the patient and say, this is what we have. And then what I think is also important is talking to the family. So oftentimes grandma has grandchildren, children, and a decision has to be made about care. What do you do in this situation? Do you want surgery? Do you not want surgery? And as the surgeon, I give information about the risks and the benefits, okay? In this case, the risk of a surgery would be bleeding, risk of anesthesia, infection, post-op, you know, there's blood loss and maybe blood clot that can happen. But if we don't do the surgery, you know, grandma will be in bed, she won't be able to get around, and things like urinary tract infections pop up, ulcers on the back, the breathing and pneumonia come out, and essentially deconditioning, right? If as little as 2 days in bed in an 82-year-old patient can really set them back. They're not thinking, they're not moving their bowels the same way, they're not urinating, all their basic functions change. And so more oftentimes than not, when I have the medical doctor who says, Dr. Lee, we think, grandma's okay for surgery. I talk to the patient and she's okay with it and the family is okay with it. Then we go ahead and have surgery. And that is what you see on the right-hand side. So in this case, as I mentioned before, I'm not able to save the hip. I'm not able to just put screws inside because it'll fall apart. That's like taking, metal screws and putting it in like soft plaster. It's going to cut right out. If you work with sheetrock, if you don't use the proper type of nail or screw that accommodates the sheetrock, if you have metal, it's just going to cut out and it'll fall on the floor. And then if you hang a picture or something, it's going to tilt. So in that case, if I try to put screws in this bone, the same thing would happen. I get an x-ray a week later and that bone would be tilted because those screws wouldn't hold anything. The blood supply isn't there. That ice cream has melted and it's not going to hold it. Okay. So the decision in this case was to replace the hip. And what does that mean? It means we actually remove the broken bone and we replace it with a metal and plastic device that allows that person to walk on it. And if you look on the x-ray on the right-hand side, you can see that there is what we call a socket, and there's a couple of screws holding it in place. And there is what we call the stem or a flute that goes down inside the bone. Now, interestingly enough, our bones, the long bones, the arm bone, the leg bone, the thigh bone, they're hollow, right? They're hollow. They're actually allow bone marrow, and a lot of interesting biology happens on the inside of the bone. And that actually allows us to put metal devices inside the bone. And oddly enough, the bone will actually grow into this. In some cases, we'll use cement and we'll, just to hold it in place. But in this case, I was able to perform a total hip replacement. And the good news is we can get grandma out of bed pretty soon. Almost hours after the surgery, if her blood pressure is okay, if she wakes up okay, the anesthesia doesn't make her too groggy, she is able to take a little ginger ale or some soup, and we say, okay, grandma, you feeling okay? We're going to get you out of bed, because our goal is to get grandma moving as soon as possible. If we do not, then we're left with the scenario I painted before, when we get blood clots, pneumonia. The other thing too, that I also tell the family, no matter what we do, if you have an 82-year-old grandparent who's got those medical issues, based on what we've learned in research, unfortunately, 10% of these people will die within a month, no matter what we do. We can do a perfect surgery. They can go through the anesthesia fine. But as the surgeon, I have to educate the family and say, listen, we could do the perfect job, but that's a consequence of being older and being subject to the stress of surgery. 10%. So 1 out of 10 people, unfortunately, will die within a month. And then within 1 year, about 30% of these patients will die. So it brings up the other point of family planning. Is your family, is this individual ready for end of life decision making? Okay. Whether it's a will, do they want to be resuscitated or not in the event that there's a problem? If grandma can't go back home because the home cannot accommodate grandma, is there a nursing home in place? Are you prepared for the financial stresses of what a nursing home might cost? And how much can grandma contribute to the decision? How much before the surgery was grandma involved in her decision? Did she say, listen, X, Y, and Z, if I'm sick, do not, pull the tube. I don't want to, be awake. Don't just leave me as a vegetable. Or some people say, listen, I want to be alive. Leave me, try to do everything possible. And what we encounter sometimes is folks don't have that plan. And then it's left to next of kin, whether that is a child, is it a spouse, is a spouse alive? And then they have to start making those decisions. And sometimes we run into scenarios where there might be an argument or disagreement amongst the family. One cousin says, nope, grandma, leave grandma alone. We're going to let her die. Or no, do everything. And it's not an easy scenario when there isn't agreement and there isn't a plan ahead of time. So I think, I painted a picture of the nitty-gritty of a replacement, but the social circumstances surrounding what happens in the event that somebody breaks their hip, really, it brings things out. The family issues come out because it forces a decision. Okay. You see who maybe the leaders in the family are, the people who step up, who are involved. And then as the physicians, I'm sure Dr. Bay sees it in ICU, Dr. Court, he has such a large practice. He has generations of patients. It's critical that there's some end of life care so that we can guide things and, decrease the stress and hopefully help people deal with, what may happen.
Yeah, excellent, excellent. Dr. Salam, we're talking about seniors, and we're talking about patients that, and Dr. Lee put it so perfectly as far as looking at what the family may want, and will grandma be able to really, contribute to the decision, and things like depression because of maybe hypertension, diabetes, or heart disease, or altered mental status because of the break and the hip break and what it's doing to her. How do we handle that from a psychological point of view?
Excellent question and an excellent presentation, Dr. Lee, an introduction to this very complicated scenario of a hip fracture. You really made it look pretty easy. But these psychosocial issues are critically important. And the key is preparation and planning. So having a healthcare proxy, someone in place who could make decisions in the event of grandma's incapacity. And you really want to have significant conversations about grandma's care and then the quality of life thereafter. Dr. Lee mentioned that there's a 10% chance of death, the cause of which is unknown, in the event of a perfect surgery, or there risks of complications that could really affect grandma's brain and her ability to think and communicate. And it's important to have a conversation as to whether or not grandma wants to live that way. Dr. Bay mentioned this collection of chronic illnesses that could really affect folks' mood. It could affect their outlook, could affect them psychologically. Some of the more common ones are diabetes, heart disease, strokes, cancer, which could be quite debilitating. It could be a visible reminder or concrete reminder of the skills and abilities that grandma once had that she now lacks. And so folks have to make decisions about whether or not to go forward. And these are important family decisions. And to the extent that you could write things down, that's really, really helpful. Now, the doctors also discussed how good a candidate grandma is for surgery based on all of these medical conditions. The beauty of youth, and many of the doctors on the panel could speak to this, is physiologic reserve. So when you're younger, you have these fresh, powerful, healthy organs that function far more efficiently. And then when you age, and as you age, these things erode, their functional ability erode, and they can lead to further and further more complications, like delirium, like change in mental status. And so these are all careful considerations that we must really undertake when we're addressing these issues with our seniors. But if someone is presenting with a profound sense of hopelessness, and grandma is talking about going yonder to the other side, catching up with siblings who have transitioned years, decades before, you really have to ask yourself, do you want grandma to hold on for her despite her suffering, or for you to avoid a loss? Very important and critical conversations to have among family members.
Excellent, excellent. Dr. Garrison, he has his hand up. Oh, excuse me, hold on. Jordan, before this, could you introduce yourself, and then I want to ask Patrick to introduce himself, and then we're going to then I'll get your question. Jordan, you're still on mute. Thank you.
Sign language. Good afternoon. My name is Jordan Garrison. I'm a general vascular and bariatric surgeon. I've been practicing for 40 years. Right now, my office is in Hackensack, New Jersey. I'm with a company, Metro Vein Centers. We have over 30 centers throughout the United States. And we specialize in diseases of veins and related illnesses like that. But the point that, I want to echo everybody's sentiments, and as surgeons, Dr. Lee and I, we're faced with a lot of questions about this. It's even so much that I recently retook my surgical boards, and a whole section was related on surgery in the elderly and the unique problems that you face with the elderly. For instance, somebody comes in and they have a DNR. First of all, we got to understand what a DNR is. A DNR means do not resuscitate, but that means if they're having a cardiac arrest or something of that nature, it doesn't mean do nothing if there's an emergency. And so you have a patient, an 80-year-old patient with a stomach tumor that is bleeding, and they said, I have a DNR, but that doesn't mean we shouldn't address that stomach tumor. Dr. Lee sees a lot of times with nursing home patients who are bedridden and they have dementia, but the nurse helps them move and their arm breaks because of brittle bones. Well, what do? Do you not fix the arm because they have a DNR? So there's all kinds of ethical questions that we have to answer. And so much so that, a lot of times the family's decision is not what's important. What's important is what the legality of it is. And then sometimes the legality intersects with the morality of it. And so it's just not difficult on the family, it's difficult on the practitioner as to what we should do, where we stand. And so we have to go talk to Dr. Salam on a regular basis to say, yo, man, I've got everything jibbity in my head. And can you help me out how to decipher this? So who gives care to the caregiver when the caregiver needs care? So these are ethical and moral and medical and legal decisions. It's a big conundrum sometimes as to what should be done and what can be done. And so it's not just an easy decision on anybody, family, practitioner, loved ones, social workers, institutions, all of that. So it is a big issue. Simply, we are outliving our organs. As time goes on, we have medicines that can take care of everything. We can keep you on a heart machine, we can keep you on a lung machine, a kidney dialysis. We can do all kinds of things, but simply, can the body withstand these interventions, or is it moral for these We used to have at Rutgers Medical School, we had a course called Ethics for Lunch. And our technology has far extended our moralities. And so these are things that have to be sat down and talked out and over and over. Now, this is the month of Ramadan. And so now you have to consider religious considerations. For instance, transplants. There still is discrepancy within the Muslim community about donating organs. And we're still waiting to hear from the higher ups to say whether it's okay or whether it isn't. And Dr. Salam, correct me, but right now it's not okay for Muslims to be donating organs. So though, if you could correct me if I'm wrong, I was just in South Africa and I asked this question to some of the holy people in South Africa, and they said they're still waiting to hear from the higher ups. So what do we do? I have an organ donation card, but I might be going straight to hell with that. Who knows?
No religious scholar am I. I am a practicing Muslim. I am fasting during the Muslim holy month of Ramadan. I'm glad you brought that up, Jordan, because the belief among Muslims is that if you pass away during the holy month of Ramadan, you're automatically granted the paradise. So if grandma happened to be Muslim, and let's say she feels at or near the end of her tether, she might actually want to transition. To Jordan's point, as a Muslim, I actually have it on my license. I'm an organ donor. And so, in Al-Islam, intent is very important. So as a physician, the intent is to leave my organs to help other people because I won't need them anymore. So, of course, I pray Allah I'm forgiven for that. But until, the scholars have settled on this question, I believe I have a sophisticated mind and I can make these judgments on my own and pray for forgiveness. While I have the mic, I would ask Dr. Lee to explain to the audience, in the x-ray, there are screws. To non-surgeons, these screws look like they're free floating.
Mhm.
So I would like you to tell the audience what they're actually screwed into.
Sure, sure. So the socket, also known as the acetabulum, that's what, we have. Okay, thanks, Omar. So when we walk, our hip is a ball and socket joint like this, all right? And in order to secure the new socket in place, there's two screws that fixate into the acetabulum. So the purpose is to hold that new cup or that new socket so that it interlocks with that ball so that the patient can walk around. Oftentimes, one other disease, if you will, that grandma, may deal with is osteoporosis, right? Thin bone that is spongy as opposed to hard. And we often need to use screws and other types of materials like cement because the bone isn't so strong. So if we don't create solid fixation, what can happen is that socket can move around. So those two screws are in what we call the acetabulum, and they're holding the cup, we call it, or the socket, the new socket in place.
So they're actually screwed into part of the pelvis.
That's correct, into the
Okay.
pelvis. Yeah,
Right.
so there's holes in that cup, and the screw head is buried into the cup, so it basically transfixes across the cup and holds the cup into the pelvis. So it doesn't rock around, it doesn't rotate. Because if grandma gets up and that rotates, and she'll be unsteady and she won't have that strength, and it'll be basically unstable. So yeah, into the pelvis, there's two screws holding it. That's called fixation of the cup. And interestingly enough, on the back side of that cup, the metal particles create interdigitation with the native bone. So believe it or not, the bone will actually grow into that cup the way that metal has been, placed on the back side of that acetabulum.
Dr. Lee, can you talk about what a fat embolism is and the prevention of such?
Yeah, so that's a tough one. Typically, fat embolism post long bone surgery. So bone marrow, which is essential to what we call the hematopoietic system, anemia, blood flow, there's fat in there. And so when we go in there with our, what we call the reamer or the device, and we're going up and down, you could show that one, Omar, if you want. In this case, I'll give the backstory here, but in case the rod you see up and down in this log bone, when we go down there with our instruments, we're disrupting that bone marrow. And unfortunately, some of that bone marrow can break loose, get into the bloodstream, and sometimes go to the lung. And that's why we're very careful monitoring these patients after long bone surgery. And typically what we see, you could see a drop in blood pressure, change in mental status, and then breathing changes. Their oxygen saturation, their ability to filter oxygen in the bloodstream starts to drop. Our normal, if you put one of those monitors on your finger, you want 100%. These people may have 100 and suddenly goes to 80. Well, Omar could certainly speak to that. And they might change how they think. They might be talking to you 1 minute and then suddenly they're up, we call obtunded, or they change completely. And it's not easy to treat. You have to resuscitate the patient, support them. But once that fat gets into the lung, Omar certainly could speak more to it than I could. It's not a pretty scenario.
Yeah, what actually occurs is the inner aspects of the bone, as Dr. Lee stated, has fat. And that part, those fat droplets or molecules get into the bloodstream. And through the bloodstream, they go up through the veins into the heart, the right side of the heart. And then from there, go into the lung. And the fat droplets, they get stuck in the vessels, the small capillaries or the small vessels of the lung. And that decreases the oxygen, which is in the bloodstream, because the blood cannot flow through the lung and gather oxygen where it should. And the patients become very, very short of breath. The oxygen becomes very low. And if this happens during surgery, it can be very dramatic, trying to get these patients through surgery and appropriately deliver oxygen to the body at the same time. Yes.
Prevention? What's the
Alrighty.
prevention?
Dr. Anderson, Patrick Anderson. Please, can you introduce yourself as well as give me your question?
Hi, everyone. I'm Dr. Anderson. I'm a board certified gynecologic oncologist. I practice out of Newark, Beth Israel, and I'm colleagues and associate with these brothers on this panel. I'd like to say, Dr. Salam mentioned a statement called physiologic reserve. And physiologic reserve is something we take for granted when we're younger. And physiologic reserve speaks to the ability for all of our organ systems, their functionality and how they integrate in order to make us function normally. And I just want everyone to understand. I came in late and I didn't hear Dr. Lee's introduction, but how does grandma get to where grandma is? And the aging process is part of that. So from a gynecologic perspective, we talk about menopause and how does menopause contribute to some of the issues that Dr. Lee on the orthopedic side has to deal with. And when we loosely talks about brittle bone and osteopenia and osteoporosis, it's a direct reflection of a normal physiologic change that occurs as a person, both male and female, get older, and those hormonal physiologic endeavors also decline. So just the way we have a financial plan and we have a way how we want to exist in life, we need to treat our wellness as such. And that not just includes, your regular checkup, but when you leave Dr. Court's office or, you leave Dr. Bay's office and you go home, you need to focus on some of the things we've been talking about for months and months and months, exercise, rest, nutrition, and understand the importance of nutrition. And when we talk about nutrition, it's not about weight loss and it's not about macronutrients, proteins, carbohydrates, fats, but also the micronutrients, right? And how those things interface and influences the endocrinologic system in our body, because it's that system that will ultimately contribute in a major way to delaying the onset of some of these aging processes, right? And you just can't always speak to it globally. You have to narrow it down. And since we talk in orthopedics, how does the endocrine system that we see in most healthy, normally aging individuals, ultimately with grandma getting to this area, and we say grandma, but also grandpas, right? And when a woman goes through her entire menstrual or reproductive life, she has a premenarchal existence. This is before before the age of 10 or 12, when her ovaries are not functioning. And then she gets to her reproductive age group, where it's from that age of 12 to, on the average, 52 to 55, where her ovaries are functioning and are making hormones. Well, those hormones not only contribute to egg maturity and her release an egg and her being able to support a pregnancy should she become pregnant, but it also has direct effect on how her heart functions, how she metabolizes fats, how she metabolizes certain minerals like calcium, right? And ultimately, since we're talking orthopedics, how does it ultimately get to influence the bones? And we know that estrogen does impact calcium absorption, calcium metabolism, and bone rejuvenation with respect to the injuries that occur during aging, or even the injuries occur during trauma, or injuries that occur through exercise as we try to maintain that wellness, right? So when we talk about, we talk about spongy bone, osteoporosis. So for the audience in general, when you see your primary care physicians, these are some of the issues that you have to discuss with your primary care physician and tell them how you feel, because some of the subtle signs of aging and how you feel, they may be subtle and gradual, and over time you may not notice them, but as you feel them, you bring them to the attention of your primary care provider, who in turn will turn around and talk to you about nutrition, wholesome nutrition, what may be happening with you endocrinologically, right? And the endocrine system is a big thing. It's diabetes, it's thyroid, it's the reproductive system. So it gets complicated. So, from a woman's medicine perspective, and like we say, grandma, but also grandpas too, is those steroid hormones that are produced by the gonads that declines over time. And how, as they decline and we endeavor to maintain our good health, how can we intervene to decrease the impact of those losses?
Excellent. Next, we're going to have Dr. James Court. You had your hand up, Dr. Court.
Yes, I did, because I just wanted to reiterate what Dr. Salam mentioned in terms of DNR, because very frequently patients don't understand really what DNR means. It just means do not resuscitate. I wish we could have another thing, like instead of DNR and DNH, if we could also have a DNT, meaning do not treat. But so far, that's not on the horizon yet,
Right.
because we're faced with this all the time.
Well, with respect to the DNR, at least I see it, again, because of the age range of people I take care of and the chronicity of the disease, and sometimes the severity of the disease. It can be dissected. There are situations where you have the DNR, which is a global kind of approach to an end of life type of a situation. But within that, there is a DNI, do not intubate, right? So you can intervene as aggressively as you want, just don't intubate. There's a situation where you can say, give me antibiotics, you can fluid resuscitate, but don't do cardioversion or a shock. So there are ways to dissect out all of that. But within that, though, if God forbid, do not intubate, and it's a pulmonary embolus, and it's a small embolus, and all I am is a little bit hypoxic, or I have a little low oxygen, that a day or two of blood thinners will help me recover, and I will still be functional and contribute to society, then that do not intubate may take away that opportunity, right? We just don't know it. So, then the family has to lean on us providers who manage these situations all the time to say, is this an acute situation? Do we have a 48 or a 72-hour window where if you do this, it will resolve and it does not become, a 2-month kind of an issue, right? And that's when it's difficult to isolate, a specific circumstance.
Yeah, I think with the DNR, I face it all the time in the ICU. And the way I think about it, and been told, and my professors who came before me, they always stated that DNR does not mean do not treat. And when you say DNR, you're really putting a stamp on it. And the patient, as well as the family, should truly understand what they're signing. And that's the most important thing. The DNI, as you stated, that means do not intubate. That means do not put the tube down my throat and put me on the ventilator to support my respirations or my breathing. That's what DNI means. DNR, obviously, do not do cardioversion or do not do CPR, as far as I'm concerned. So it's just so important from a physician standpoint, as well as a family standpoint, and also as far as the patient is concerned, that if a family has a question or they truly don't understand the parameters of DNR, DNI, that they get their questions answered prior to signing the paper. You should fully understand what you're signing. And long as you're educated about what you're signing, I'm fine with it. But it's important that it's well explained. Dr. Jordan Garrison is next. And Dr. Lee, we didn't forget you. We're going to keep going on this one. Dr. Garrison, go ahead.
As surgeons, and Dr. Lee, I hope can, add on to this as well as you, Omar. I guess everybody can. But I get the question, patient has a problem, comes in, I need to do surgery, and the family goes, but they're not strong enough to undergo surgery. So it comes into what is preoperative intervention, what is preoperative clearance, as a so to speak. And each one of you have your own specialty, and you'll be able to say, As far as the surgeon is concerned, there are a couple of parameters, 3 things that we look at. Nutrition. People say, well, the patient hasn't been eating, therefore they're not strong enough. And what we can do is look at we look at the albumin levels. And if the albumin level is normal, that means that they're nutritionally able to undergo surgery. If the albumin level is abnormal or low, then what we do is a nitrogen balance to see if they're losing or if they're gaining. Now, we don't have to correct that before surgery, but what we have to do is make sure that they're in a positive nitrogen balance, that they're moving forward. It doesn't have to be normal. It just has to be on an upward rise. That's the first thing. Also, hemoglobin, or your red blood count, or how much hemoglobin you have, oxygen carrying capacity. You know, people use the number 10, that it has to be 10, but it doesn't have to be 10. I have operated on patients as low as 6 with a hemoglobin, as long as we support them and as long as we monitor their vital signs. And then the other question is, what is the most important thing for an elderly patient undergoing surgery? Is it that they have a positive nitrogen balance? Is it that they have a exercise program? Because sometimes people say, let's delay the surgery so that they can kind of build themselves up to surgery. All of that goes out the window. The most important parameter for an elderly person having surgery is that they have a post-operative rehabilitative program. So Dr. Lee was talking about getting patients up out of the bed within 24 hours or even shorter. Incentive spirometry to get those alveoli popping open and doing those things. Nutritional support, all of those things. So post-operatively is where the real serious efforts have to be put in to decrease the morbidity or mortality from surgeries.
Yeah,
All
I'll
righty.
chime in here if you don't mind, Omar.
Yeah.
Yeah, so I think Jordan brings up some really good points. The other thing that we look at is chronologic versus physiologic, right? Somebody could be 100 years old and in really good shape. And I'm sure all of us have seen the 70-year-old who looks like they're 90. Smoker, poor nutrition, poor health, don't exercise, maybe some family history of some comorbidities. I see it all the time in the orthopedic world. And then from chronologic, physiologic, then you have elective versus emergency. So in our practice, elective surgery is planned. We say, okay, Mr. So-and-so, before I do any type of joint replacement or surgery, you're gonna see Dr. Court, your cardiologist, and we're gonna make sure every organ system is ready to go. Your nutrition is there. If you're a diabetic, your hemoglobin A1C is under control. You're not smoking around the time of surgery. And we're gonna plan a date, and we're going to plan, to Jordan's point, a post-op course for you so that we know whether you're going to go home or you're going to go to a rehab, and we're going to like line it up as best as we can because we don't want to create a lot of variables. Now, unfortunately, that goes out the door when you have the 88-year-old who comes in with a broken hip that's on dialysis, heart attacks 2 weeks ago. It's like that's the card you dealt with. And then at that point, you're relying on, your internal medicine colleagues to at least give you the risk benefit ratio, how risky it is. The anesthesiologist can chime in as well, the intensivist too. And then you have to have that really open discussion with the family, say, hey, this is dicey, I'm going to do my best. I can't promise you the surgery hopefully will go great, but how the body will react, we don't know. We can't always predict it. I've had patients that have cracked jokes 2 days from surgery, and then a week later they're dead. They're laughing, and all of a sudden that reserve we talked about, they've used it up. And then unfortunately, they reach the end. So I think, those are also things that we pay attention to from a surgical perspective.
Excellent.
Really?
And,
Dr. Lee, I have a question about hardware that orthopedic surgeons use. Are there scenarios where screws, plates, and rods that are inserted into joints or bony structures that they're removed? Is there a situation where they're removed? Could you explain that?
Sure. My typical spiel with the patient, say they have a broken bone. We'll go over a case scenario shortly where maybe they get a rod put down their leg. The majority of the time, we want that rod to stay in place for about a year to allow the bone to heal. What we have found is if you take that out too soon, they can refracture. The risk goes up if it's under a year. If you have a very skinny patient, they might feel a screw or two. They might, sometimes the screw will migrate or move some, it can loosen. Think about the scenario of a paper clip. If you take a paper clip and you just do this back and forth, you do it long enough, it's going to snap. So in our bodies, sometimes those screws are subject to force we call tension or compression. You walk, you run, they can sometimes break. And so in that scenario, you remove it if it causes an issue, if it moves around or it irritates a tendon or muscle. And in a very rare scenario, the person can be allergic to the implant. We don't know, we sometimes will screen for nickel allergies, but a lot of these alloys, the implants have a nickel component inside. If we're lucky enough or we screen ahead of time, I'll say, Mrs. Jones, when you put on jewelry, do you get itching on your neck? If you wear rings, have you ever had scenarios where that bother you where you can't wear jewelry? If we screen that ahead of time, we will change the implant choice that is a non-allergy causing metal as well. So there are scenarios where there's either rejection of the implant, migration of the implant, or it bothers the patient, somebody who's thin, and it's like, what, can I take it out? And most of the time, what I counsel the patients is, if it doesn't bother you, leave it, because that's another surgery, another anesthesia that they have to go through. But there are scenarios where we have to remove the implant.
So most hardware is placed permanently.
Correct.
Mhm.
Correct.
All righty. Dr. Court, your hand is up.
My question was to Dr. Lee. How do you deal with those patients who come to you and says, oh, my father is too old to have back surgery?
Yeah. So, it's delicate. What we typically do, if I meet somebody who's say in their late 80s and they're struggling with back pain or some joint pain, and the family is convinced they're too old, we think about pain management. How has that pain been managed up to that point? What have they done? It's not always a surgical treatment. Actually, it's pretty rare, to be honest with you. If you look at my clinic, and if I see 40 people in a day, 3 to 4 are surgical candidates. The remaining 36, I'm doing injections, physical therapy. We have shockwave treatment. We do diagnostic x-ray. So more commonly than not, they're not getting surgery. And especially if they're older and high risk, we say, okay, you have a bad back, you might have degenerative arthritis in your spine. Let's see about some physical therapy. Have you tried that? Have you tried basic medication? Have you tried an injection? I talk about the treatment ladder. At the bottom of the ladder is you don't do anything, you live with it. And then we go one step up. Medication, physical therapy, one step up. An injection, a little bit more invasive. From there, if that doesn't work, then are we at a point where we're talking surgery? And oftentimes in the elective setting where I've seen this patient and their family, I've gotten to know them for 3 to 6 months. And I say, and they may reach a point where they say, Doc, I can't do it anymore. I just can't live like this. I've seen them. I met their family. We've had multiple discussions. I feel like I've gotten to know them. They've gotten to know me. And then I just try to paint scenarios. Okay, in the last 5 years, I had this patient at this age. This is what happened. There was an unfortunate, event, maybe. Just be as open and honest about what could happen, the reality of what I'm experiencing as a physician, and then try to, explain that to the patient and make it real to them so that they can make the best decision. I think the days of, doctor, just tell me what to do. Just, it's in your hands. Like, we have patients in our community that are like that. I'm sure all of us run into that. Just tell me what to do. It's not I feel when the patient is educated, they're informed, the family's informed, and they can make the decision with you, I feel like that's the best scenario. Sometimes you really have to guide them, but if they can make an informed decision, that way you both feel good about, the outcome, right? You explain what could happen, what could go wrong, what could happen if you don't do surgery versus if you do surgery. Will you get swelling post-surgery? Did you expect that? Did you expect that knee was going to be stiff for 6 weeks? Did you create those expectations so that it's realistic after you've done a procedure and people really know what to expect? That's, called informed consent. Were they really informed about what they were getting into?
All right, excellent. Dr. Garrison, you're next.
This is for Dr. Salam. First is a thank you. I too am fasting. And as I was sitting here, there was a bowl of raisins next to me and I just stuck my hand in it. It was like, so thank you for the reminder to your fasting. So I appreciate it. But my question, or I don't know if it's common, an absolute where I don't do surgery is and I've canceled surgery as the patient is going in the room. When the patient says to me, hey, doc, I had a dream last night that I died. Cancel, right then and there. I do not take them in the operating room, okay? So I just want to share that with y'all.
Was it them that died, Jordan, or did you die, Jordan?
They said, and if I don't wake up, you're gonna die too.
Talk about a sense of premonition and foreboding, right?
Yes, I would have canceled that as well, Jordan. I would have canceled. Dr. Anderson, go ahead, please. Patrick, you're on mute.
Yeah, so when we talk about aging and some of the joint issues that folks are afflicted with, we tend to focus on the hip, we tend to focus on the lower back, we tend to focus on the knees. But as someone who was active, played a lot of sports, I often know and was afflicted with understanding that your shoulders is probably one of the more susceptible joints to injury, not just from trauma, but also from wear and tear. Can you talk about shoulder affliction, rotator cuff injuries, Dr. Lee?
Sure. So
actually, there's a question with the rotator cuff too. So we can, once you get into this, I'll read that question. Okay.
Good. So thanks for the question, Patrick. I think looking at our joints and just comparing how they're different. So as we talked before, the hip is ball and socket. That's called a constrained joint, right? It is socked in with ligaments, and the bony anatomy creates a suction cup effect. So you can't really do much with the hip. It can move around, but it's not going to pop out easily, right? So same with the knee. The knee is the main plane of motion is like back and forth. We call flexion and extension. And again, it's a constrained joint. There's multiple ligaments that tie it together. The interface between the bone basically locks it in place. Now we go to the shoulder. Very interesting. The shoulder does this. We do this. We reach around our back. It has more degrees of freedom. And the anatomy of the shoulder is a shallow joint. It's not a constrained joint. So you have a socket that it's almost flat, and then you have a ball. So there's much more rotation. There's much more movement. And around the shoulder, it's constrained loosely by ligaments. Imagine if your shoulder was constrained completely and you're doing this. You're stuck, right? Based on our ancestry, history, we had to reach above, climb trees, whatever we had to do. And the purpose of these upper extremities was allow us multiple degrees of freedom. The lower extremity, they have to be solid because you run on those, right? You don't want those wobbling all over the place because then you can't run. So if you're an overhead athlete, if you fall down, or you're constantly doing overhead activities, especially as we age, the muscles around the shoulder called the rotator cuff, there's 4 of them. They allow us to raise, move to the side, go behind our back. When we age, the tendon, which is the muscle to bone attachment, ages with us. So I commonly tell patients, like, look at Kobe Bryant's career, right? As he aged, God bless him, may he rest in peace. But if you look at him from a young Kobe Bryant to an older Kobe Bryant, 2 major injuries. He tore his Achilles and he tore his rotator cuff. He was 35 plus, playing 18 years of professional basketball, a lot of miles. So you have a guy who's in his mid-30s, a lot of overhead activities. The tendon itself, the blood supply changes, the cellular level changes. So instead of having the elasticity and the movement, inflammatory tissues and degenerative cells start to creep in. And that's why people say, well, I can't run like I used to, or I can't jump like I used to, or I can't throw like I used to. Well, you're aging. And I think when you subject your shoulder to the stresses of when you were younger, when you're older, and the tissue itself doesn't accommodate you in the same way, that's when you start getting attritional tears, or maybe even acute tear like Kobe Bryant, where he went up to, I think, dunk a basketball and comes down like this. And that's something he had done over and over. It wasn't anything he hadn't done in his career, but the perfect storm and scenario happened where the aging met the activity, and the activity, unfortunately, was a little too much, and it caused a tear. And so then once this tendon tears because of aging and attrition and cellular change, you can't lift it. Oftentimes, if you're what I call high demand, meaning you're a professional, you need to do overhead activities, or your job requires you to be active, more times than not, we're going to have a surgical discussion about trying to get you back. And what I tell patients oftentimes, especially with the shoulder, it's meant to be a loose joint, but after surgery, you're going to be stiff. You're going to be stiff for about 2 to 3 months. You're not going to wake up from surgery doing this. You're going to be in a sling, because we want that tendon to heal back to the bone after we've anchored it and sewed it in place. If we start moving you too soon after surgery, it's just going to re-tear because it's super delicate after surgery. But in my population, I see a lot of weekend warriors, a lot of people that are golf, tennis. When can I play golf? When can I play golf? When can I play? Like, 'tis the season. I get people all the time. And I try to explain to them that if you have a large tear that requires surgery, minimum of 3 months, because, you know, you have to rehab it, you have to get the motion back, and you're going from a stiff shoulder to now physiologically we're used to a loose one. So when you have a stiff shoulder that's healing, that can be a struggle for a lot of people. It takes them time. And it's one where oftentimes I'm a cheerleader. I'm like, 4 weeks after I saw you the last time, listen, you got another 20 degrees, go for it, you know? And I hope the next time they get another 20, 30 degrees and more motion, and more times than not, they do get the range of motion back, but occasionally they're stuck with a little bit of stiffness, and, you know, that's a whole nother discussion.
Dr. Lee, could you speak about Achilles tears? I have lost count of the number of brothers who cannot give up running ball, and they burst their Achilles. I'm seeing it over and over again.
Right.
All right. But before, Dr. Lee, let me get this question out, because we're in rotator cuffs, and then we're going to do the Achilles. All right, Dr.
Okay.
Salam?
Yeah, and Omar, I just want to say something while he's on the rotator cuff issue, and then we get into the Achilles tendon.
Okay. The question is, for a torn rotator cuff confirmed by MRI, what is the most effective treatment? Steroid intrathecally or PT?
Okay. Good question. A lot of times it has to do with function. So I have patients who have large, full thickness, completely torn rotator cuffs that will come into my office and they'll do this. They'll lift me off the bed with a full tear. And I have people with partial tears that come in the office and do this. I don't have a great explanation as to why. So for me, it depends on the physical examination, how old the tear, how acute it is, and then how much pain there is. Very commonly, people that have acute tears with pathology will say, I have pain at night, I can't sleep, I turn on my shoulder, it hurts so much. Those are the ones where, like, all right, I'm probably leaning towards a shot, where like they're very uncomfortable. If somebody has a tear that's more attritional, they might have a little bit of pain, but they're pretty functional, or maybe they lost motion. We'll talk about physical therapy. So it really depends on how symptomatic it is. You know, what their metabolic status is. Are they diabetic? Do we not want to introduce a steroid that would raise their blood sugar temporarily? Is there an associated frozen shoulder that doesn't allow them to move, where we will start with physical therapy to get the motion back, and then from there consider either repairing it if they have weakness, or just further rehab. So to me, it depends on the patient's baseline function, how much they lost, and then that dictates how aggressive we'll be, whether it's a physical therapy, injection, or maybe surgery.
All righty. Patrick, you had something?
Yeah, with respect to, the rotator cuff, the testimony is, I had, was one of those weekend warriors who, at 45 want to behave like I was 25, playing soccer every week, playing in a high stress position, tore a rotator cuff, and, went through the spectrum of intervention, as Dr. Lee mentioned, and ultimately couldn't function in the operating room, dropping instruments, those kind of electrical type pain going down the arm. I had the first rotator cuff repaired, and then, after the rehab, thought, well, what took me so long? A few years later, the other shoulder started behaving the same way, and I met our good friend, Dr. Lee. He did the exam, did the evaluation, and he didn't dance around the issue. He said, your functionality, your youth, and your health, youth at that time, dictate that your best outcome is probably surgery. And the testimony is, our colleague and friend, Dr. Lee, got in there and did what he needed to do and made the adjustments he needed to make. And, I walk now with a full upper body balance. I don't feel like I need to adjust, or, and I do surgeries every day now. And it's almost like I'm 25 again. But Dr. Lee, I'm not going to act like I'm 25 again. He warned me about doing military presses, over the head stress exercises, those kind of things. And so far, it's been a good almost 6 years.
Excellent, excellent. All
First
right.
of all, Patrick,
Jordan, you want to talk
how
about
did you
Achilles, or
injure
do you want to?
yourself? You weren't even playing real football. You were playing football.
Jordan, could you come closer to your computer?
Yeah, I was saying, Patrick, how did you injure your shoulder? You weren't even playing real football. You.
So you know what you guys call football really isn't football, because you're carrying the
Get
ball
outta
with your hands more often than you carry it with your feet. But let me tell you, in real football, you have the goalkeeper who uses his hand 100% of the time, and you have people like me who was breaking falls 100% of the time. I can't always break a fall with my feet.
But I do have a comment.
Mhm.
First of all, Dr. Lee, I like you very much, but I don't like surgeons, and I've had, like Patrick, really playing on a high level of sports throughout all my life. I have had multiple sports related injuries. And again, you would be the expert based upon function, but I have never had a surgery for any of my injuries. And I strongly believe in rehabilitative medicine. I'm almost excessive. I'm from the LeBron James school that, those German doctors are good, in doing rehab. I had sciatica, serious sciatica, and doing back exercises and core exercises. I don't have it anymore. Of course, you don't operate on backs, and I'm glad of that. Your first line of is therapy.
Right.
And I'm totally with it. I've had nerve injury in my neck, just like Patrick. I couldn't lift my right arm to raise the light in the operating room. And, with physical therapy, traction, and some anti-inflammatories, it took time, but with a dedication to the physical therapy and the exercise program, I still feel like I'm 35, at least in my brain. I'm not responding like I'm 35, but I'm not my age. Physiologically, I'm not my chronological age, and that's due to a rigorous exercise program.
Okay, this is what we're going to do. We're approaching that midpoint, so we're going to take this break and pay some bills here. The thing of it is that, and when we come back, Dr. Lee we'll go with Achilles, okay? And when we could just remind me, because I know I get off track sometimes. So just give me the high sign. We're going to talk about Achilles. And then we have quite a few questions here. So I'd like to start servicing some of those questions. And then from there, just to give you a plan. And then we're going to go into your video, which it's an excellent video that Dr. Lee put together. And I definitely want to leave time at the end for that. So let's go with this. At this particular point, let me let the docs introduce themselves. Dr. Court, can you start us off and we'll rock and roll.
Dr. James Court, my specialty is internal medicine. My office is located in East Orange, New Jersey.
All righty. Dr. Lee, once again.
Dr. James Lee Jr., orthopedic surgeon, Essex County.
All righty. Excellent. Dr. Salam.
Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist. I practice in Philadelphia.
All righty. And Dr. Jordan Garrison.
Jordan Garrison, board certified general bariatric and vascular surgery. I specialize in diseases of the venous system and practice in Hackensack, New Jersey.
All righty. Dr. Patrick Anderson.
Yes, I'm Patrick Anderson. I'm a gynecologic oncologist. I take care of women with cancer of the reproductive system. I practice in Newark, New Jersey.
All righty. And Dr. Nelson Aluya. Welcome, Nelson.
Yes. Good afternoon, everybody. It's a pleasure to be here. Yeah, Nelson Aluya, medicine pediatrics trained, presently Chief Medical Officer of the North Community Health Centers, Federal Health Qualified Centers here in New Jersey. It's a pleasure.
All right. Thank you very much. Remember, every second Saturday, tongue-tied here. Every second Saturday, we are here on Zoom at 1 o'clock. Just go to OBHealthy, click the physicians area and come in. We welcome you to come into our webinar and ask your medical questions, please. The most important thing that I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of your medical problems, all righty? If you want to see our prior webinars, just go to OBHealthy and scroll and hit the YouTube sign. All of our webinars are there. Please subscribe. And also, I would like to thank OBHealthy for allowing us to bring this platform to you, okay? Dr. Lee, let's talk about Achilles.
Sure. Dr. Salam brought this up, but he has a lot of colleagues that he's run into with, that torn Achilles. So, there's mythology, Greek mythology regarding Achilles. There was one area where he was in the river Styx and it was exposed, and that one particular area wasn't fortified, if you will. If you look at the human body and the Achilles tendon in particular, about 5 centimeters above your heel bone, the calcaneus, there's what we call a watershed area in the Achilles. That means blood flow from above through vessels and the bottom, they meet, but there's a gap. And so as you can imagine, if there's a gap and there's that one little area that does not get that same blood flow, that same nutrition, doesn't have the same elasticity, more commonly than not, that is the spot that tears. And so when they'll say, oh, I feel like somebody hit me with a hammer, or they hear like a gunshot, that's when I'll bring up Kobe Bryant again. When he tore his Achilles, he looked up to the defender. Did you kick me? Like you could see, hey, what did you do to my leg? Nothing. It failed. And what happened was, we call this an eccentric stress, a stretch, acute stretch and contraction, pop. And what happens is, as we age, that watershed area, the elasticity, the content, the collagen content, we go from a very organized collagen to disorganized. It's not the same. It doesn't expand, contract. It doesn't have the same push off. So when that person runs, jumps, or whatever kind of sport they're involved, they'll go, oh, and then the majority of the time you do the MRI, it's like, they'll say Achilles tendon rupture, 5.3 centimeters proximal to the calcaneus. It's almost all the time. And, sometimes there's it pulls away from the bone, but more times than not, it's that actual weak spot that tears. And as I mentioned, as we age, we just don't have that same elasticity, and it's not uncommon.
Excellent, excellent. Let's do another question here, okay? So since we got quite a few. 73-year-old female. My knee has started giving in while I am walking, and there's a potential for falling. I'm wearing a knee brace today. So I think she just wants guidance, or what do you think about that, Dr. Lee?
Sure. I think it definitely warrants an evaluation. If this represents a change for you, this person who's asking, it warrants an evaluation. What I would want to know is, do they have a knock knee? Are their knees starting to come together, or are they going bow-legged? Is the bow-legged getting worse? Is the knock knee getting worse? Is there a change in the anatomy, or has there been some type of soft tissue injury, whether a muscle or ligament around the knee has been stretched or injured? As I mentioned before, the knee is a constrained joint. It really is only supposed to bend and flex. It rotates a little bit, but if you change it just the slight amount, the knee will start to misbehave. And it can be anything from the bone contour not being smooth, like when we're young, so they have arthritis, so now they're called like bone on bone. So instead of walking on a cushion, and they're now bone on bone, almost like the tread on the tire is all the way down. Or it could be a ligament that's causing it to move, or wobble back and forth. We call that instability, or sprain. So if I see that 73-year-old in my office, I do a physical exam, I check the ligaments, I check how much it can bend, and then I do an x-ray of them standing up, and I look at their knee joint, and I see, is there asymmetry? Is it tilted to one side or the other? And then I can then counsel them, say, listen, you've gotten wear on one side, so that's why you're kind of going off and veering. These are your options. We can maybe give you an injection, we can do some therapy, and then from there, decide how your body reacts to those treatments.
All righty. Excellent. I was reading, sorry about that. I was reading a question. Another question real quick, and then we'll go forward. Good afternoon, all. And hopefully, I know this is pediatrics, and you're not a pediatric orthopedic, but maybe you can give some guidance. Good afternoon. Good afternoon, all. I want to know, how would you proceed with a 5-year-old whose right leg is externally rotated and she walks on the balls of her feet? Is it
So,
something that you can give us some guidance or?
yeah, it depends. I want to know, was it always like that? Immediately after birth, there's things that come to mind where, there's equinus people, there's toe walkers. So there can be children that, for whatever reason, behaviorally or physiologically, they walk on their toes. And if it's one side only, it's a little concerning. Could there be an underlying neurologic condition? Was there an intrauterine type of event? Did they have a club foot, where we call that kind of a packaging disorder, where in utero, they might have had a club foot, or they might have had a birth where they were at risk. Was there a family history? Is there anything neurologic that's causing it to be maybe in spasm? There's so many different things. It could be from cerebral palsy, club foot. It could be physiologic toe walking. I'm sure Nelson could comment on this as well from his pediatric background. That it starts from packaging on the inside when they're intrauterine, and then when they come out, what's going on. So I'd want to know how long it had been there. Is it something new? Was there an injury, or is this something that was developmental? And there's a consequence of that. I certainly would recommend a pediatric orthopedic evaluation. There's so many things called like metatarsus adductus, where they just point in, they could point out. Sometimes it's as little as physical therapy, stretching, but I'd really want to make sure it's not neurologic. Wasn't from intrautero. Maybe there was an insult there, or maybe there's a developmental issue. And then from there, we could offer some more guidance.
Yeah, excellent. Nelson, do you see this at all, or?
Yes.
And if you see it, how do you direct it? Do you send it to orthopedists?
So Dr. Lee.
Before Nelson say anything, I was looking at a response to the question. They actually said this was congenital.
Congenital. Okay. So it's congenital. So then, if it's congenital, then you might have a fixed deformity where there's an imbalance between muscle and tissue. I don't know if Nelson, you've seen it, but in my residency, I saw a lot of club feet, where basically it's a packaging issue, and it's an imbalance of the muscle and tissue, and it causes the foot to be flexed, rotated. And there's different ways to treat it, from serial casting, where you basically are trying to get the foot and ankle to behave by casting and then stretching it a little bit. And then basically every single week you're trying to adjust the cast in order to get that foot to behave. Or you do a lengthening of one of the tendons, and then you might do what we call an osteotomy. You have to basically crack the bone and realign it. So if it's congenital, then we need to know origin. Like what is it? Is there a neurologic component where there's a spastic issue as well? Is it coming from the brain that we may not be able to fully correct? Does it require some type of neurologic intervention, such as like an injection to sort of loosen some of the tendon? Or is it behavioral too? So I think if it's congenital, then it certainly it requires a deeper dive there.
I'm sorry, go ahead, Nelson. Did you have something to add?
Yeah, no, I say he so graciously gave such amazing differential diagnosis. If it's congenital, if it's something acquired, if you developed at birth, or is it something that sudden happened, or something that's been chronic, all of those. But on top of that, there's a condition called LCPD, leg calves patches disease. It was first described in 1910 by, I think, Dr. Arthur something Leg in Boston Children's Hospital. That's not that common, but it does happen, where you have the blood supply to the head of the femoral bone, which attaches to the hip. For some reason, temporarily, that blood supply is cut off. It's not that common. It's usually only on one leg, but in 10 to 15% of the cases, it occur in both cases. However, it's commoner in boys than girls. And if it happens in girls, a whole lot more worse than anything else. But the first time that children present with this, they tend to limp. They may have a little pain in the front of the thigh, and then if it continues or persists for a long time, they begin to have a lot of pain in the hip, and they limp a lot. Now, there's different stages that, this thing happened to a point where it's called avascular necrosis of the femoral head, where the blood supply to that head is cut off and the bone begins to degenerate and wears off. But because they're young, it usually happens between age 4 to age 10. But because they're young and the body really regenerates so quickly, over time, between 1 to 2 years, it regenerates. But the problem is that if it's not diagnosed early or fixed properly, then the usual socket head that's smooth would not take place. So over time, there's a little bit of abnormality in that joint, and that child would no longer have the smoothness of the work that they ideally need to have. So treatment for that, or early diagnosis, treatment is usually can be in 2 ways. Physiotherapy, pain medicines, but in very severe cases, you have to do surgery where the pediatric orthopedic surgeon will have to go and clean up the area and patch it up so that the bone growth would come back smoothly again and the child will do well.
Yeah, I'd like to piggyback on that. Thanks, Nelson. So if you compare ethnicities, there's another condition called SCFE. I'm sure you see it, Nelson, a lot in our community. Slip capital femoral epiphysis. Very common in African-American community, typically heavier set African-American boys, where the growth plate in the top of the femoral head is loose or it's not calcified enough, and their weight causes that femoral head. I used that analogy before of the ice cream scoop on the ice cream cone. It slips off. And so in Perthes, parents who smoke and typically more European ancestry, SCFE tends to be more, it can happen in any community, but typically African-American. What we typically do for the Perthes patient, and again, this comes from training, is called containment. You just want that, you want that femoral head to stay in the socket. It can develop more normal if it stays where it's supposed to be. If it comes out, then you have a problem. You mentioned the blood flow changes, the development of the hip. It's critical early on, intrauterine and beyond, for that femoral head and socket to stay in location, because it can develop the way it's supposed to. Now in SCFE, it tends to be more traumatic as growth happens, as early puberty happens. Maybe there's an individual who has delayed puberty, and because of their heavy weight, that growth plate is weak and it falls off. And those typically you fix them. You go in and you put screws, because if you do not, you mentioned a condition called avascular necrosis. The blood supply does not work. My father commonly says that's called a stroke to the bone. It's like the bone doesn't get the air and the blood supply, and it falls off, and then it can be permanent, and they develop arthritis early on in their 30s, 40s, and 50s. So, we've seen patients 30 years ago that had SCFE, were fixed, and unfortunately, sometimes they've developed osteoarthritis, or sometimes they don't. But I would want to do sort of a ethnic comparison of those two disease processes in the hip, where you have one community affected by the Perthes and the other more by SCFE.
Excellent, excellent. Dr. Garrison, I want to ask, go ahead and answer, let you ask your question, but we have a lot of other questions to answer that from the general audience as well. So, and I want to get to that video. So let's
I want to keep it very, very brief. When you're talking about Achilles tendon injuries, one of the differential diagnosis, and this from personal experience, is rupture of the plantaris tendon. It's the same sort of injury. I felt like somebody was shot me in the back of my leg. I turned around, there was no one there. Yeah. And it's a vestigial remnant. Right. It's absent in about 20% of people, but 80% have it. And it mimics an Achilles tendon, but a physical exam will say that it's not an Achilles tendon injury. And the second thing is, when I was a child or going through puberty, was Osgood-Schlatter disease, where it was pain at the tibial tuberosity. I just had this terrible pain in my knees, and it was just growth plate injury, not even injury, just growth plate growth. Could you comment on those two things?
Yeah, I see this a lot. I've had a couple of interesting scenarios of patients. So part of the tibiotubercle, that's where your patella tendon inserts on your leg bone. If you feel below your kneecap, you go about 4 or 5 centimeters below that, you'll feel a bump. So when we're growing, the apophysis, or the top of the growth plate, the apex, isn't mature. It's still calcifying. And what I see commonly is our young athletes are training so hard that their muscles are stronger than the bone. And they can be so strong where the muscle contracts and they'll literally pull off the bone. It'll cause an avulsion fracture. Now, what you were describing was microtraumatic stress reactions at the level of the growth plate. So from playing soccer, football, you're growing at the same time. It's like a race, you know, your body's growing and saying, listen, I need time. But, you know, the child in us wants to play, they want to compete. And so oftentimes it's so painful that they cannot. And the treatment typically is rest, stretching, and letting the body catch up. Now, in this day and age of super competitive athletes, I've had a young man who's 15 years old. He's 6'5". Both parents, Division I track athletes. They came to my office. They're both in the medical profession. And they said, we want our son to run in the Olympics. So he comes into the office and he's like, I've got this hip pain. You know, he ran the 400, 200, very competitive. Like he's definitely will be Division I and beyond. He's like, I had this hip pain. And we're like, you know, I was concerned. He said it happened right at when he started his sprint. And so we get an x-ray and it turns out where his hip flexor attached to the pelvis, he pulled off a piece of bone. He was that strong and he was still growing. We got his x-ray of the pelvis still showed open growth plates. It pulled off the piece of bone. And so we give him a break, 6 weeks, and he's like, comes back at 6 weeks later. And he's like, I feel great. You know, I want to get back to training. The parents are, you know, sort of cracking the whip and their expectations are really, really high. And I'm trying to explain to them, I said, listen, and this kid is, you know, pardon the term, but he's jacked, like he's ripped, he's huge. He's like very muscular, but he's still growing. And I was trying to explain that to the parents and listen, you have a young man, the dad is probably 6'7", the kid's going to grow more. And I'm explaining that this is going to take some time. He needs to rest. His body has to catch up. So lo and behold, he does well at 6 weeks. 6 weeks later, he comes in, he says, you know what? My left hip hurts. I don't know what's going on. The top of my pelvis hurts. You know, they had me doing a drill where instead of me running the traditional way around the track, they had me running backwards and the other way. And then the inside hurts. And so I feel on his pelvis and he's painful, he's tender. Get an x-ray and he avulsed the growth plate off the top of his pelvis, right? And that's where the glutes attach. And so again, it's the lesson learned here is, are we overtraining? Are our kids overtraining? Are they doing too much too soon? And are we creating these expectations that we shouldn't? And, you know, I think finally it set in with the parents that, hey, listen, he's doing too much. And, you know, I hate to be like, you know, I don't want to preach to people, but if your child breaks 2 bones in his body within 2 months, something's wrong. You're doing too much. And so I think the lesson learned was you don't want to overtrain. You have to let the skeleton mature. And I think a lot of us want it now. We want that, you know, we want to be ranked now. We want that, you know, the YouTube video out there, the social media exposure. We want like, you know, that immediate expectation of what we can accomplish. But the body will tell you it's not ready or it's not quite fit for what we're trying to get it to do. And as a 15-year-old, I tell people, listen, you're a sophomore. I was like, you have sophomore, junior, senior year to still compete, to still grow, to still get exposure. But oftentimes that short-term gain is what they want. I'll say, listen, if I gave you $5 and I told you to hold on that $5 and next office visit, I'll give you another $5. But if you wait 3 months, I'm going to give you $50. You know, what are you going to do? And sometimes they're like, oh, I don't know, maybe I want that money right away. But it's kind of like the investment. Will you invest in the long-term aspects of your body? Will you give your body a chance knowing that you probably still will get major scholarship looks? You'll get those offers. But if you're hurt, you won't get any. You won't be able to compete. So, you know, when I'm counseling a high school athlete, if they come in with a major injury, what happens is they get flagged in the locker room when they go to their combine or they're going for their scholarship evaluation. If they've had an injury and a surgery, they get a red flag. It's automatically in their chart. It follows them their entire career. So if you have somebody who is high school, like ACL tear, Achilles, guess what? If they make it to Division I, wonderful. They make it to, you know, training camp, all over their chart, and it follows them. And so, you know, I've had colleagues or people who are professional athletes. I had a gentleman who played football for Tulane. And when he played football for Tulane, he was a projected 5th round pick. They said, okay, we like you. He's offensive lineman, 5th round pick. He goes to his combine doctor evaluation and they do a MRI of his neck. He shows a little bit of arthritis. They did like an MRI of his hip, labral tear. He went from a 5th round pick to out of the draft. Okay. So he dropped from a guaranteed money to 0. So then he goes to camp. He actually went with the Giants and he got cut. He didn't make it. He played 2 weeks for the Giants and he was around Jason Pierre-Paul's era. So my point is, if these young men and women overtrain and they do it in high school, that's major consequences. You might lose that scholarship. Imagine having 4 years of paid college that you can't get now. You know, that's a big amount of value, right? And then, you know, further yet, if you go professional and then you can't get that contract, you don't get a long-term deal, you get a 1-year deal because, man, I don't know if that knee's going to hold up. So we're only going to give you a 1-year deal. So these are all things that we try to explain and try to counsel, but often that instant gratification can take over the parents' expectation, the coaches. I've been a team physician in Newark for my entire career, 15 years. And I can tell you the culture of getting these kids back on the field, like I'm the enemy because I'm looking at them at my age. I'm like, all right, I don't want that 15-year-old to have a bum knee when they're 40 and they can't chase their children around, or they can't, pay their mortgage, or they can't, make, your high school coach is not paying your car bill. He's not paying your mortgage when you're 40, 45, 50 years old. And so for me, I tell parents, I'm looking at you not only at 15, I'm looking at you at 50, because I see the 50-year-olds now. I see the 55-year-old NFL player that hands come in that look like boxing gloves and their knuckles are huge, fingers are crooked, bad hips, bad knees. You guys saw, I'm sure Shaq just had a hip replacement, right? How old is Shaquille O'Neal? Right? He just had his hip done. He at the prime of his career, you got this 7 foot, 300-pound guy, but even Shaq, who we look at Superman, needed his hip done. So, when I see it on more of a high school, college level, I'm often looked at as like, well, why are you trying to hold me back? Or, I try to say, listen, I'm looking at you long-term as well. I want you on the field, but what are the consequences of what could happen to you if we get you back there too soon?
Mm-hmm.
Excellent, excellent. I'm so glad you went there as far as the topic was concerned, because our young people, as well as parents, need to hear that. Definitely. There are quite a few.
Dr. Bay, I mean, what he just talked about is very critical. And a lot of the time, people don't understand that when, you try to tell parents about things like this, even screening them for a physical before sports events. As a matter of fact, every child needs to get a physical done, even for the pediatrician. And then they get the EKG and all that. And if it becomes abnormal, then you have to get them to see the cardiologist and all that. And they feel that you're holding them back. I think we need to find a ground or common place, or have a talk with the sports industry so that they be on board, and understand what the medical end of it is trying to portray, so that everybody understands, and not just for today, but for the future as well. And like you said, Dr. Lee, instant gratification is what people want to see. And once they get that, they think, oh, it's okay. But they don't see for the rest of their life, after age 30, 40, and you live up to be 50, 60, 70, you're going to be in pain for the rest of your life. Your coach and everybody else is no longer there. You have to deal with that. So
Right.
I think it's an advocacy issue that must be put in together so that everybody be on the same point, just like they did with the what do you call it, traumatic brain injury issue that became such a big topic right now.
Yeah, it's a conundrum. I had my own little soccer academy, and Dr. Lee knew about this. And we have these kids in tournaments where we have scouts from different colleges, and it's all about the scholarship. But I think the conversation is not just between Dr. Lee and the patient. It's Dr. Lee, the parents, the patient, and the coach. Because at the end of the day, the long-term consequences of incompletely treated injury, is greater ultimately than that scholarship which that young athlete is unable to get.
Excellent, excellent. Dr. Garrison.
I'm glad you brought these topics up, and Dr. Lee and I have participated with these athletes on a level, and the bottom line is about the money, and it's the trickle down of the money.
Mhm, mhm.
And I've been on both sides of that, whereas I had a son, or I have a son, who was a gifted basketball player, and he was having some knee issues. And I okayed it for him to play one more game with that issue. And it got worse. And he went to a camp where he was scheduled to be a D1 4-year scholarship player. And because he couldn't compete at that camp, they just forgot about him. And so I understand it to the tune of him playing at a D2 school, which does not have scholarships. And now I own a wing of that school because I had to pay for him to go to school. Okay. So I understand. And even when he was playing at that school and he had injuries, the coach just moved on. He's like, yeah, I understand you have an injury. We got some physical therapy for you over there, but they just moved on. Well, what about his medical issues? Are you going to pay for his rehab and his therapy? He's like, well, we really don't have money for that. And they recruited another kid to play his position. So the next year he was SOL. So we see it on all levels, and the parents get the fever. And for a moment, I had the fever too. Oh, look at this kid, he can go to the pro and stuff like that. So, yeah, I don't think we're going to get much movement from the coaches. I don't think we're going to get much movement from the NCAA. And even with that lucrative money hanging out there, I don't know. Once that parent gets the fever, it's going to be hard. It's extremely hard to get through to that parent. My kid is going to be the next LeBron James. My kid's going to be the next major league pitcher, and rotator cuff injuries, elbow injuries, all those stress induced. But I just want to ask one question, and this is kind of an ethereal question for the future. As our technology improves, we have the ability to give biological implants.
Mhm.
We can give false knees. We got people running a 400-meter dash with mechanical legs, titanium legs, and things like that. My thought is eventually, what is going to be the legality or the logistics of a football player who gets an artificial knee and that knee has a little bit of a motor in it? We have these micro motors we can put in bicycles to increase performance in the Tour de France. I think it's just one step away from them putting them in knees or joints or tendons, and will these people be able to compete? So that's just for the future.
Right,
What do you think?
yeah, I think it's not quite the answer, but in the parallel comparison, you have identity politics and gender.
Mhm,
You have your trans community competing.
mhm, mhm.
And what's the right answer, right? If you have some type of advantage, whether you are a trans female or male, and you're competing against I don't really want to say the opposite sex, or maybe your former sex, and you have some type of advantage, or Jordan mentioned, you have some type of technological advantage as well. It's an ethical question. I don't think there'll be an answer. I think there'll be, a lot of politics behind it, and no clear answer. I think as the physicians, our job is to counsel about the consequences. What will this mean for you, your patient, and the future? But I don't know if we're in the political realm. It will have. I'm sure there'll be some influence. But I think as a physician, we're like, how will your physiology change? What are you going to look like at 5, 10, 20 years down the line? If we put this type of implant, are we just doing this implant? Like, there are athletes that just want to play for a contract. They don't care about 10 years after they're retired. If you do something in their knee, it's going to be arthritic or worn out, but that pitcher can get another 3-year, $30 million deal. They will take it. They will take it. They will live in pain. They'll take their Toradol. They'll get their shots. But if they can get that another 3 years, 30 million, they're going for it. And those are the guys that are like 35, 36, 37. Can I just get one more deal? One more deal. You can see, like, the Mets on their pitching staff, they have 2 guys pushing 40 that they paid $40-50 million to, that who knows what their shoulders look like. They're Cy Young, winners. They're, one of them is a World Series, both World Series champions. If you took an MRI of their shoulders, I guarantee you it'll look not physiologic. There'll be changes, but those guys want that money. and they're going to do what they can to get it. And, you know, what we have to worry about in our community is like knowing the percentage of that athlete being low to go professional, making sure they're in school, right? You're in school, learn something, learn a trade, learn, you know,
But-
get an advanced degree so
Yeah.
that you created value for yourself, because
Right.
we know that the chances of them going to the NBA, NFL, whatever they want to do is very low. But you got to make sure that they've at least created some type of value for themselves outside of sports, you know, maybe using sports to get a scholarship, but you know, if it's not going to happen, you know, you have to pivot and hit the books.
Yeah, that's the
so
socio-political
powerful.
conversation, right? Because at the end of the day, you know, we tend to have these conversations in silos, right?
Right.
But we need to put it in perspective and simply ask yourself the question, whether it's the NFL, the NBA, or Major League Baseball, how many jobs are available per year, right? And how many athletes on the junior level in high school and in the D1 college platform that could even perform that they become eligible for a draft, right? So now you have to say to them, listen, stop looking at the dollar sign, build your infrastructure. And your infrastructure should not just be athleticism, but also your academics and your baseline health. And the true survivors of this conundrum is the ones that create a balance, but that's not just a balance, but a valued balance. They're great athletes, they're student athletes. I mean, you think of how many NFL players you know who actually went to medical and law school. There are a few of them. And the ones that do are actually the ones that have longevity in the sports, right? So, you know, so we have to say to the parents, listen, you know, what is it that you value? Right? And then the silence become really loud.
Right.
Because that money, again, the converse is also true. How many of these guys get the same big contract and a few years stop playing and they're broke?
Yeah.
Because they lack the educational acumen as to how to even manage their own situation. That's the disaster.
It is.
Yeah.
So it's great to have a young kid that's a great athlete, but it takes a kind of broad spectrum counseling. Look at your athleticism, nurture your health, but also develop academically.
Yeah. This is a great topic, and with our kids and our families and everything, I trust we could go on with it. I just want to pull back to our questions because we got quite a few here. I'm just going to say thanks to Cheryl for talking about her 94-year-old dad and how well he did as far as his hip surgery is concerned. Oh, was it hip? Let me see. Come remember. Yeah, hip replacement. He's doing well, and I'm glad for that. There was another question. I sustained a broken pinky toe. Oh, pinky toe. That's a good way to say it. About 3 months ago. As a result, from a car accident, although the toe is healing straight, it now appears to be floating, i.e. touching, not touching the ground. Is this a cause for concern? Is there anything that I can do non-surgical to restore back to its original? Can you help us out with as far as that's concerned? You have a floating toe, but it seems to be straight.
Yeah. I think that warrants an evaluation. So our toes, just like our you know, the pinky finger has a tendon, right? It bends and extends it. And if there's a broken bone, that could contribute to malalignment, or there could be an imbalance between the tendon that flexes and extends the pinky toe. So I think it warrants a further evaluation, whether it's a soft tissue imbalance or maybe some therapy will stretch it out, or is it the bone isn't healed the way it's supposed to. That definitely warrants an evaluation for sure. It doesn't necessarily need surgery, but it needs diagnostic information, you know, to really counsel this person on what should happen.
Okay, and thank you. Another question: what are the complications that cause a total a total knee replacement to pop out of socket, and you end up with an emergency room visit?
So for a total knee to pop out of socket is concerning, because I mentioned before that the knee joint is somewhat constrained, right? It has degrees of freedom when you flex and extend it, but if it moves out of place, that means it's unstable. So my concern would be the metal to metal interface where there's plastic in between. Maybe the plastic has loosened so that knee doesn't conform the same way it's supposed to. That is concerning. That sounds like maybe a mechanical failure of the hardware, where there's an actual bearing that is out of place or something happened. Definitely needs x-rays. It really depends if the surgery was done recently or is it long-term. That also plays a role. There are instances where a low-grade infection can slowly cause a problem with loosening of hardware that appears as an acute issue, but may have been festering for some time. So I would want to know when was that surgery? Was it recent? Is it a long-term issue? And then based on, we would do x-rays, CAT scan, blood work to make sure there's no infection. And then from there, it may have to be, redone or changed. I'm not really sure.
Okay, another question, does the
Is
weight
old
of your
wives-
arm, the
is
flab,
old wives'
has
tale
anything
that
to
you
do
don't-
with the pain in the rotator?
The flab in the arm?
Yeah, if you have a lot of flab or your arms are large, does that, would that cause rotator problems?
I don't know. Maybe Jordan can come on this. If you've done your weight loss surgery, do you get people with residual skin? I do see it. I'll have patients who present with shoulder issues and they might have had a weight loss surgery and they have residual, redundant skin and they might have atrophy. I would say it may be related, but I don't think the cause. Rotator cuff typically has its own intrinsic wear, like it wears itself, or there might be acute injury. But the only thing I could relate is maybe deconditioning. If there is, atrophy of the muscle from inactivity, maybe that contributes to shoulder pain, but I would say probably not. I wouldn't say that it is related.
I would agree with that it's not related. You may get some muscle fatigue or some rashes or things like that, but that's not from the wings.
Yeah, exactly.
Quickly.
Yeah.
Old wives' tale or not. If you have a broken toe, you don't have to do anything about it.
Majority of the time, you buddy tape for 3 weeks. That's it. Unless it's deviating to the side where shoe wear is an issue. I think in 15 years, I've reduced 2 toes in the office because they were deviating, and we just reduced it. Did a little local block and put it back. But the old wives' tale is pretty accurate, and most of the time it's buddy tape and 3 weeks, and usually it's okay.
All righty, excellent. All right, what I'd like to do is, Dr. Lee, I'd like to go to your PowerPoint.
Oh, okay, sure.
All righty, and let's see exactly what you put together here. I think, let me see if I can do this quickly. Hang in there with me. Let that get out of the way. There we go.
So my daughter there, who looks little, she's 5'10" now, was insane.
Oh
11
my goodness.
11 years old, 5'10". She looks me in the face now. It's crazy.
I love it. I love it.
Unbelievable.
All righty, let's see if we can, hold on. If I don't know what I did there.
Maybe
Something that's not supposed to happen.
slideshow, maybe, or
Yeah, the slideshow is behind it actually for some reason. Do you see the slideshow?
I see it upper left.
All righty, give me just one moment and we shall
Right there, slideshow.
do the slideshow one more time. Hold on, let me enter this screen showing the stuff. And I think I clicked it out completely. And I am sorry, Dr. Lee.
all right.
Hang in there. You could go on to a different topic while I see if I can bring this up again.
Sure. What is I would certainly defer to the internist. Maybe Nelson can help. One of my fears as a sports medicine sideline physician that I haven't really encountered, but we've seen recently in football Buffalo Bills with Mr. Hamlin, is an on-field cardiac arrhythmia.
It's interesting, Dr. Lee. I was watching one of my favorite team, Manchester United, play, and Christian Eriksen, the Danish player who had a cardiac arrest and had to be resuscitated on the field, went to the hospital. Now I think has a pacemaker in. I'm not sure what kind, and he's back playing at a very high level. So it's funny. We have parallel thoughts today.
Yeah, no, it's true. We're prepared. We have, a team. Like currently, I'm the team sideline doc for East Orange campus football. We have EMS there. We have a defibrillator. We have a trainer. But I'm still, as the orthopedist, I'm a little bit of fish out of water. We have our standard protocol, and we want to check rhythm and see if there's an issue and perform our ABCs and CPR. But I would say as a sideline orthopedist, that is one of my concerns. I was recently at a course in Washington, D.C., where there was an emergency room physician, and they have a big MedStar health system that manages like everyone from the Redskins all the way down to all the local high school games. And they have a team in place. So for myself, having an EMS trainer there, but the event of a cardiac, I haven't seen it yet, but I know one day it's going to happen. And seeing it on TV, I know it seems like it's going to come closer to home. But I don't know if there's any tidbits anyone has for me to say, all right, this is what you need to recognize, or is it just kind of follow your, I'm ACLS certified, but as an orthopedist, that's not what I'm doing every day. It's like the Matrix for me. I'm looking at that thing like, what? But I certainly would take anyone's recommendations, what to do, a cheat sheet, in terms of creating comfort on the field there.
All righty, we'll have to talk about that.
No
All right,
worries.
well, this is the slideshow and we will begin.
Yeah, so the question here is, what is osteoarthritis? We've been talking about joint pain, wear and tear. This is a diagram of the hip, and it essentially is inflammation of the joint from wear and tear, and it wears out. And in this case, you have a picture of a hip, and it shows the wear and tear, and it's very painful. People start limping. They won't walk the same way. They might need a cane or a walker, and they come to me because it hurts. So we can go to the next slide. In terms of hip osteoarthritis, 88 per 100,000 patients per year, people per year. Knee is a little bit more common. And, it's something that in my practice, I would say knee followed by back, followed by hip is probably what comes in the door most frequently. Next slide. Causes, and this is osteoarthritis. This is the wear and tear. There's other types of arthritis. That's another, we could talk about rheumatoid, which is an autoimmune, gouty arthritis, infectious, but we're going to talk about the wear and tear type. Age is a factor, just living, wear and tear, obesity, being heavy, overweight, putting a lot of force on your joints. We've mentioned in the past, if you walk up and down stairs, that's 3 to 5 times your body weight goes on your knee joint. So if you're 200 pounds, you go up and down a step, that's 1,000 pounds of force on one knee joint, just going up and down between gravity and your body weight. Increased loads, again, same type of point. And then if you've had injuries in the past, we just talked about our high school athletes who get hurt in high school. What do they look like when they're 40, 50, 60 years old? Do they get premature wear and tear because of, an injury that occurred in high school? I can't tell you how many times a young lady or man in their 40s has come to me. I hurt my knee in high school. I know I did something, but I never did anything about it. And then I'm looking at a bone-on-bone arthritic knee at 45. And so that's also, and then is there a deformity? Is this person really knock-kneed? Are they very bow-legged? Is that part of their family history that, they have arthritis? Is that part of the equation as well? Next slide. What are your symptoms? Pain, limping. You can't move the joint the same way. It's stiff. It's inflamed. Next slide. When we make the diagnosis in the office, outpatient clinic, we're looking at x-rays commonly, physical examination. And then if we need to, we'll do higher imaging studies such as MRI, which looks at soft tissue and bone, CAT scan, which is very good at looking at bony anatomy 3-dimensionally. And then in some cases, we'll do blood work. Is there an underlying infection? Is there an autoimmune issue we have to investigate? Does I also see patients with lupus or sometimes autoimmune condition, rheumatoid arthritis, that will screen them for blood work to see if that is causing some of their issues. Next slide. Non-surgical treatment. Well, Dr. Bay's whole, one of his purposes is you got to talk about healthy living, right? We want to live healthy, right? The whole OBHealth talks about, it's in the title, living healthy. We want to make sure that we have a balanced diet, that we're not just eating meat, and we're not eating processed food, healthy living, healthy lifestyle, ranging from diet, exercise, sleep, good mental health. That's all a big part of, what goes on here.
Excellent.
And, talking about this, you live a healthy lifestyle. If you don't have processed food causing inflammation, you tend to do a little bit better. If you can keep your weight down, keep the weight under control, you're not going to wear those joints out the same way. And then, motion is lotion. Our joints like motion. If we can stay active, keep the joints loose, You know, we all have a little bit of lubrication in our joints. That's what God gave us. And if you can keep moving, then there's a better chance that you won't get as stiff. And then in terms of treatment, anti-inflammatory medicine, if you're not allergic, Motrin, you can go Tylenol, and in some instances we'll give a steroid injection. There are some new, more biologically, friendly treatments that we can give, such as PRP, which is platelet-rich plasma. That means we draw some blood, we concentrate the platelets, and in those platelets, there's anti-inflammatory qualities, there's healing and growth factors that actually can offset some of the effects of the degradation of arthritis.
Excellent.
Next slide. And in terms of when we finally get to the point where we've done everything else, we discussed it earlier today about total joint arthroplasty. That means joint replacement, knee replacement, hip replacement, shoulder replacement. We have a panel of physicians that are specialized in their respective specialties. And as the orthopedist, I rely on them to say, hey, how healthy is your patient that referred to me? Are they even a candidate for surgery? If they had an active heart attack last year, they needed stents and they're on Plavix, maybe it's a no-go. So oftentimes we'll risk stratify. How risky is this surgery? And then will the doctors who see this patient give us a letter stating that they're okay for surgery? And again, this is mostly the elective setting. In the emergency too, we also want the guidance as well. What are the risks? It's about 2%. The surgeons in the room can certainly comment on what they see, but with total joints, we see blood clot. That's DVT, not uncommon. If we did a total knee and did not do any prophylaxis for blood clot, 80% chance of a DVT, 80%. So you essentially guarantee the patient to have a blood clot. They can get an infection depending on their status. Are they diabetic? Do they smoke? Do they have any underlying illnesses? It bleeds during surgery. We do our best to control the bleeding, but we are operating around blood vessels and tissue that does bleed. We do our best to correct that. The young lady who presented the hardware failure, going to the ER because the knee popped out. It does happen. It's a man-made prosthesis. Nowadays we have robotic assisted knee and hip replacement. We do our best to put everything perfectly in place. Even so, it's man-made that sometimes cannot work. And then stiffness. Even if we do a perfect knee replacement, there's some people, I'm sure Patrick can comment on, who develop scar tissue, much more robustly than other people. We see it in the knee, we see it in the hip and the shoulder. You might go 50 cases and no issue. And then you have one person that 6 weeks after surgery, they're barely moving the knee because of what we call arthrofibrosis or scar tissue. Are they predisposed? Are we seeing it more in our community? When you see someone with the earring and they have a keloid, are they at risk for making extra scar tissue because that's what their body does? It does happen. I have changed my knee replacement protocol. I try not to even cut the muscle anymore because I don't want to set off a physiologic scar if I don't have to. So I actually cheat the way I do it, so I don't make my incision down the middle. I go to the side, I lift up the quad muscle, and I do the knee replacement and I put it back. Whereas when I first started, I was cutting the tendon, I was moving the muscle, I was splitting it apart, and I was seeing more people getting stiff, especially in our community. So I was saying, wait, what, how can I avoid that? What can I do to minimize that, minimize the need for narcotics, minimize the need for aggressive physical therapy? And one way is a muscle sparing approach where you're not cutting the muscle anymore. Next slide.
Excellent.
Here's the knee joint itself. It is 3 total parts, the medial, the lateral, the inside part, the outside part, and then your kneecap part. There's ligaments that hold it together on the outside and the inside. And as I said before, it's somewhat constrained. It's not going to move around. If we walked around on loose knees, we'd have trouble. So the way, God made it, he created a constrained joint where you just flex and extend. You sit in a chair, your knee will bend. You go up and down stairs, it'll bend. When it becomes arthritic, it doesn't do the same thing. You have trouble getting in and out of your car, maybe sitting down in the bathroom. When I talk to patients about how are your ADLs, your activities of daily living, are they really affected by your knee or your hip or your shoulder? That also guides our decision-making on whether we're aggressive or not. Next slide. And here's a great picture, a side-by-side view. On the right-hand side, you see the bone on bone. That's when there's no cartilage left. That person said, oh, my knee slips out of place. It does a weird thing. It's starting to point to the side now because the bony anatomy has changed. And this oftentimes is a wear and tear phenomenon. There could be a genetic component, but when I do the x-rays in the office, I always do a side-by-side view because I'm looking for this. This is what I'm looking for to counsel the patient about how bad is that knee. And when they're bone on bone, you know, the majority of the time it's very painful, and they become surgical candidates if their x-ray looks like that. Next slide. Here's the approach I mentioned before. Now I don't make that cut in the middle anymore. I say, listen, I'm gonna go on the side where letter C is. I'm gonna go below the muscle because I don't want the body to make extra scar tissue after the surgery, because I want to avoid that knee being stiff. So when we're in there, surgeons, this is what we're looking at. You know, the muscle tends to be red, the tendon tends to be white. In this day and age, as we advance our care and technology, we want to do less disruption to the body as we can, because we don't want as much bleeding. We don't want the muscle to atrophy and shrink, and we want that person up and moving as soon as we can. Next slide. And then here's just someone who had a muscle sparing approach, you know, right after surgery, you know, went to see them in the hospital. And this person, I think, took one pain medicine after surgery. And you can hit play. So when was your surgery? Are you in any pain right now? Lift up that leg for me. So lifting up, they're already doing a full straight leg raise. Didn't cut the quadriceps tendon. They can flex to 90 degrees post-op day 1. So the advantage of that for this patient is less hospital time, less narcotics, hopefully less swelling, and maybe they avoid going to a short stay rehab. They go home as opposed to going to another facility where there's exposure to germs or whatever, other patients. And so when you do these muscle sparing approaches, that it's advantageous when it goes well. Next slide. Here's a gentleman, same thing, muscle sparing surgery. He is 10 days after on the left. No brace or anything. And then on the right-hand side, this is 3 months after surgery. Soccer player.
Okay, go ahead. Total knee replacement. How long ago was it? Yeah, jump. Yeah. Good. Wow. Excellent. That's perfect.
Now, everybody shows their best, right? We all show our best results. But as a physician being practiced for 15 years, I definitely have had unhappy patients. But of course, I'm on a platform, I'm going to show you my best. But, you know, the reality, not everybody does this well. But if we can steer people in this direction, and you notice this guy's not heavy, he's not big. You know, he went in, had a surgery. He's back in the office 10 days out. He hasn't had to be in a rehab center. And you're showing what it can look like when it's successful and things kind of line up. Next slide.
Yeah. Okay, go ahead.
And this is one of my typical patients. You're looking at mid to late 70s, 2 days stay at the hospital.
Walk for me.
10 days. She's off narcotics after the surgery, and she went back home, right? So, you know, elderly person off narcotics, less chance of them being constipated or having the effects of the mental health effects of a narcotic. So we're really trying to help people recover faster by doing, you know, this is how a muscle sparing approach will help this person not be in as many narcotics and not be in the hospital as long. The hip, again, I'll go over this quickly. Ball and socket joint. It's a major weight bearing joint. Joint 5 times your body weight when you walk or go up and down stairs. Next slide. The anatomy of the hip. There you have the ball and socket, like we mentioned before. It's very constrained. This is like suction cup. Your hip it's not going to pop out. If it's popping out, there's a problem. So the femur bone is below, the socket is there, which is kind of where it interfaces, and that's what it looks like. Next slide. On the right, ooh, that's a bad looking hip. So that's bone on bone. It's almost out of place. If you compare it to the other one, there's essentially a normal looking x-ray, and that is very painful. But normally you don't see that bone on bone arthritis. You don't see the wear and tear. And when somebody with that hip that looks diseased comes in, they're limping, their limb lengths might not be the same. They probably have a cane or a walker, and that's very disruptive to their life because you're asking the body to bear 5 times your body weight on a very diseased joint, which can be quite painful. Next slide. Surgical treatment. We mentioned this before about hip replacement. There's different types of metal. A lot of them are nickel alloys. So pay attention to any type of metal allergy in your history or family. Oftentimes the implants are plastic with the metal backed area. Some of them we use cement to hold them in place. On the lower left, you see that the pink one is ceramic. We also use ceramic because the wear characteristics are good. It'll be very low wear over time. You can get often 10 to 15 years of wear out of the hip joint. So we try to create biomaterials that are patient friendly and will last as long as they can. Next slide. Here's hip replacement surgery. We showed this earlier. The entire arthritic hip is replaced. Inside our bones, as I mentioned before, the long bones are hollow. So we put a flute or a stem down one side. And as I showed you before, you have your ball and socket that goes on the other side. Next slide. Here are our components, kind of going over this again. People ask, well, what is it made of? What does it look like? Well, this is what it looks like. If you were to completely take it all apart and have a puzzle piece, you have the stem, which we mentioned goes in the bone, the head part, and then you have the socket, plastic liner, and that all interfaces into your native socket. So when you're walking, it's like ball bearings. It's very smooth. And instead of it being bone on bone, it's now plastic with a metal interface and a ceramic area. So, you know, it's like having a great cushion. Next slide. Another view of that. Next slide. And then the main benefits. Why do we do it? We want to decrease pain. We want patients to be able to get around. We want them to not, you know, go from a walker to a wheelchair. We want them to go from a walker to a cane to hopefully nothing. And we want to improve the quality of life. Next slide. Here is a gentleman, broke his hip. He came back to the office maybe a week afterwards. He's in a short stay rehab.
Towards me. How you feeling? You want to get out of there? Yeah, sure. Just have a seat for me if you don't mind. And it's okay, I shared with my other doctors, okay?
So what as a doc, I'm laughing on the inside because I did his hip surgery a week ago and he's like, "Oh, get me out of there." So you know he's doing okay because he wants out. And so I didn't really need any other signals to know that my patient's doing fine. He broke his hip, I replaced it, and he's out of the wheelchair walking a week later. Get me out of there. So I know he's ready. Like, you know, all of us know those signals, those kind of like unwritten rules are like, all right, I think he's doing okay or not okay. In this case, he's doing okay. And this young lady had a very arthritic hip. You know, we did sort of a pre and post. This is her walking. She had a cane, miserable. She was very miserable, had a very arthritic hip, and she couldn't really get around. And then afterwards,
So you had your surgery, please walk for us. How do you feel?
I feel wonderful. I feel great.
Good. And your recovery's going well?
Recovery is going excellent.
Good.
I wish they all did this well, but you know, not everybody's this well. But these are good examples of people that have done quite well because they went from very arthritic and miserable. You know, if you get their pain from 9 to 2, they're happy. You know, if they take a Tylenol every 3 months, they'll live with that, and they're extremely happy. And I think part of it too is like patient selection. You want to make sure that it's on the right patient, and in these individuals, you know, it seemed to work out pretty well.
So you had your hip surgery?
Oh yeah. And then this was a hip replacement we did a couple years ago. I couldn't believe it. I mean, I was blown away too. And he's dancing after his hip. I can't even remember which side we did, but he was doing just fine. So again, we all show our good stuff, but you know, it can be funny when it works out well. It can be a lot of fun. So thank you again, Omar, and the rest of the panel and the people watching. It means a lot to be able to present and show us what we can do.
Right. Excellent. 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 I'm so glad you put that slideshow together. Even though we talk about it a lot, we talk about many aspects of medicine, to actually see it and to see the patients and to see what we do and how we do it in the recovery and possibilities. I'm just so glad you put the slideshow together.
Oh, thank you
very much. I know that we are basically out of time, but there's one thing I'd like to do prior to us leaving. This is a picture here. And hold on for a second. I would just like to see, no, I'm not going to get fancy because I got fancy last time. Oh, as I said, I'm not going to get fancy. But the thing of it is that this is a picture. And the reason I brought this up, Dr. Lee, is that your father, and you always say that you're second generation.
Right, right.
Your father is He's a pillar in our community. And I don't know how many years. How many years has he been practicing
So
medicine?
he graduated medical school in 1965 from New
Hmm.
York Medical College. And yeah, he has been, let's see, 19, in this area, New Jersey was 1973. And
Mhm.
so, you know, one of his claims to fame is, you know, obviously being a pillar in the community. One of the first African-American practices he joined, it was with Dr. Ellerby Washington, Dr. Buell Staggers, and Dr. James Lee. When my dad was a young guy, he joined the practice. It was like the practice, you know, in our community. They were based in Newark and East Orange, Crippled Children's Hospital, if people remember, United, you know, they go way back. And so my father's evolved over time. He is a pioneer that brought arthroscopy to New Jersey. He was one of the first physicians to ever perform arthroscopic surgery in New Jersey. And he's taught many residents and other doctors, and, you know, obviously been a mentor for me and dad. And, you know, to see him retire, he's, you know, 80, almost 83 years old, and was still doing, you know, wonderful surgery and taking care of patients. And, you know, I always tell people, like, my shoes are this big, my dad's are this. I can fill a little bit, you know, I can do some, and I certainly have taken away a lot from him, and I've learned a lot. And, you know, he's also, you know, he's just been a wonderful leader. And I think all of us have had some type of interaction or positive experience with my dad. And it's just, you know, everywhere I go, it's baffling to see the influence and impact, somebody that's been a pioneer and just stayed in the community and done wonders. So thank you for showing that. It means a lot.
Well, I just like to say who's in the picture. And the reason we took this picture, we were at the doctor's, you know, Doctor's Day or
Doctor's Day
Doctor,
celebration, yes.
at for the hospital. And they presented an award to him because he's retiring and at this particular point. And I'm so happy that he's able to retire, number one, and that he had such a successful career. Let me show who's in the picture here. This in the blue jacket, that is the chairman of the board of Beth Israel Medical Center. Then there's your dad, Dr. James Lee Sr., and then, of course, Dr. James Lee Jr., and then the fourth person is Mr. Darrell Perry, who's the CEO of Beth Israel Medical Center in Newark. I'm just so proud of what your father has been able to do, and I just wanted to recognize him because he's been an inspiration, a teacher to all of us. I mean, I remember it so many times in the hospital, he's guided me. So I'm just thankful to have those senior people there when I needed them. And I'm thankful the fact that he's able to retire and partake in this part of his life.
Yeah,
Yes.
thank you. Thank you very much. That means a lot.
All
Yes,
right.
I'll pass on to him as well.
So actually that's about all we have today. Excellent presentation, I want to say. So as far as us closing, and I'm so thankful that everybody out there could join us today. I'm thankful for the fact that we had a lot of questions on orthopedics and we were able to answer those questions, and look forward to you joining us next time. What I'd like to say is thank you to OBHealthy for allowing us to bring this webinar to you. Number one, please check out their website with the weight loss and the health issues and all of the things that they have to make you healthy on their website. Remember, second Saturday of each month, we're here at 1 o'clock. Please tell family and friends, as well as, I'll tell your enemies as well. They can come and listen to us as well. The most important thing I can say before we leave is please do not change any aspect of your medical care before you consult your physician. Only your doctor, truly only your doctor can, you know, take care of you at the best, all right? If you've missed any of our YouTube videos, or go to YouTube and you can find all of our past videos, all right? You go to OBHealthy, click on the YouTube sign at the bottom of the page, and it will bring up the whole channel. Please subscribe. All right. I look forward to, you know, just having you be here next month. And until then, everyone be safe out there. All righty. Peace.
Five.